Alterations in integument, burns. Burns are tissue injuries that are caused by heat, chemicals, or electricity. The severity will be determined by the temperature of the heat source, the duration of contact, the thickness of the tissue that is exposed, and the burn location. Thermal injuries cause coagulation of proteins in the cells. Chemical injuries liquefy tissue and loosen cell attachment. And electrical injuries cause damage to the tissues or organs from the entry point to the exit point and in various places in between. Cardiac dysrhythmias, central nervous system complications. An inflammatory response will extend the initial burn injury, causing ischemia and tissue necrosis. More serious burns can actually cause a hypermetabolic state requiring increased oxygen and nutrition. In this issue, the fluids will shift and electrolyte disturbances will occur when the fluids move to the burn, causing intravascular loss and fluid loss from the wound. Anemia, renal failure, gastric ulcers, and inhalation issues can also occur. So true or false? Burns can affect fluid balance. This is true. Burn depth will be assessed from the color, skin characteristics, and sensation of the burn injury. With the superficial or first-degree burn, this is going to be similar to a sunburn. A superficial partial thickness, which does not cause scarring, or a deep partial thickness, which can cause scarring and may also require some debridement or skin grafts, is a second-degree burn and is dependent on the amount of the dermis that is burned. A full thickness burn destroys all layers of the skin. It's painless. The skin will be charred and also requires debridement. Fourth-degree burns involve ligaments, tendons, muscles, nerves, and bones. The extent of the burn injury needs to be determined quickly in the emergency department when trying to guide the treatment. A quick initial method of estimating how much of the client's skin surface is involved is called the rule of nines, in which areas of the body surface are assigned multiples of 9. Excuse me. Another quick assessment technique is to compare the client's palm with the size of the burned wound. The palm is approximately 1% of a person's total body surface. And then we also have what's called the Lund and Browder method, which is the most accurate method to determine the extent of the injury. However, it can be difficult to use in an emergency. So true or false? A burn severity is affected by the temperature of the heat source. That is true. Inhalation injury should be suspected whenever the client complains of a sore throat, they have singed nasal hair, eyebrows, or eyelashes, they have hoarseness, there is dark, sooty sputum or carbon in the sputum, edema of the face and neck, soot around the mouth or the nose, shortness of breath, or stridor. If burns occur to the face, neck, or upper chest, inhalation is a possibility, and we should be monitoring closely for complications. Inhalation injury is associated with swelling of the airway, inhalation of carbon monoxide, and respiratory failure. Some of these clients do require mechanical ventilation. True or false? An infection within a burn wound can be life-threatening. And this is true. So how do we treat burns? Well, initially, our first priority is to prevent further injury. We have to smother that fire and observe for any respiratory difficulties. Oxygen and IV fluids should be administered as soon as possible. Acutely, we will assess the extent of the burn injury and any additional trauma. Again, oxygen and/or mechanical ventilation may be required. Fluid resuscitation. So again, the first two things are oxygen and IV fluids. We may need to do a bronchoscopy, a tracheostomy, apply or place the client in a hyperbaric oxygen chamber, administer analgesics, and a tetanus immunization. With the wound, we remove the clothing to the area as soon as possible, clip or shave area in that area, cleanse the mouth and lips, irrigate their eyes, cleanse wounds, and apply topical antimicrobials. The open method of wound care exposes the wound to air. It does require isolation, and we have to keep that room warm and humidified. It also involves debridement to remove crusts or eschar around the wound. And it may also require an eschorotomy, which is an incision into the eschar if that eschar begins to constrict the area or impair circulation. The closed method application of dressings and antimicrobials could also be used. And one of the medications we might use is a sulfonamide, which is a broad spectrum antibacterial. We can also use it often in UTIs, but it is really good in a topical preparation for burns. It is contraindicated if there's a drug allergy. Women who are pregnant should not use sulfonamides, or infants younger than 2 months. It can cause allergic reactions. It can also cause photosensitivity or sensitivity to light. It can cause issues with the GI, hepatic, renal, and hematological areas. We need to encourage fluids with oral preparations. With burns, make sure that you're using a sterile glove to apply a thin layer of the cream. Frequently, the preparation is called silver sulfadiazine. There's another topical antibacterial that we might use, the nitrofurazone, which helps with bacterial skin infections, wounds, or burns. Adverse effects include erythema, pruritus, dermatitis, rash, edema, or inflammation. The medication is commonly called Furacin. It would be contraindicated in someone that has large total body surface area burns. Additional treatments to promote heating include debridement. a skin substitute application, or skin grafting. Debridement is removal of that necrotic tissue, and it can be done 4 ways. It can be done naturally, mechanically, with enzymes, or with surgery. A disadvantage to debridement is bleeding. A skin substitute is a temporary covering, and skin grafting covers large areas of burned tissues. It does lessen the risk of infection. It minimizes fluid loss, diminishes pain, encourages tissue regeneration, reduces scarring, and prevents loss of function. Hypertrophic scarring can occur in large wounds when skin substitutes or skin grafting are not used. Sources for skin grafts include skin substitutes that can be applied as soon as the wound has been cleansed, an autograft, which is the client's own skin. We remove a stamp-sized area of skin, which is then cultured and transferred to burned areas. We could do a split thickness, full thickness slit graft that allows the graft to cover more area. Disadvantages include more pain from a new wound, where they do remove that skin, scarring from that donor site and risk of infection to the donor site, a delay of wound closure, and increased medical costs. An allograft is human skin from a cadaver. A heterograft is a skin graft from animal skin. We can use a pressure garment to help reduce scarring and wound contractures following a burn. Silicone therapy is the gold standard to burn scar management because it reduces redness, flattens raised scar tissue, and improves elasticity of scar tissue. They can also be used with pressure garments. So nursing management includes wound care, addressing the client's psychosocial status, making sure circulation has been maintained. So we're going to do that fluid replacement, treatment for shock and pain relief. Again, wound care, so we teach about the application of antimicrobials, dressings, we monitor for infections, provide emotional support, and teach the client exercise to help minimize contractures. We teach about adequate nutrition, pressure garment, skincare measures, and the use of sunscreen.